Hello again. My name is Dr. Betty Dube, and this is part 3 of the thyroid disorder series. Here's the captioning statement to remind you that the captions, if you are to use them, might be up to 90% accurate. In this session, we'll be covering hypothyroidism. So we'll go through the epidemiology, etiology, and pathophysiology of hypothyroidism. We'll also review the signs, symptoms, and characteristics of hypothyroidism, as well as its diagnostic pathways. We then delve into the mode of action, cautions, contraindications, interactions, and side effects of the main classes of drugs used in hypothyroidism. Here's a recap, just to remind you again where the thyroid gland, and that's where the thyroxine hormone is produced, but significantly also to remember that it is activated by the pituitary, and that's where the thyroid stimulating hormone is produced. Again, the anatomy of the thyroid hormone, just to remind everyone where that is. And the terminology we'll be using again in this part of the endocrinology series. Back to classification again, we do have two main types of thyroid disease. We have the hyperthyroidism that we covered in part 2, and today we're covering hypothyroidism. And here in hypothyroidism, we have primary, secondary, and tertiary. So hypothyroidism simply means reduced thyroid hormone production, leading to slowing of metabolic processes throughout the body. Think back to the functions of the thyroid hormone. In contrast, sharply with hyperthyroidism, where everything speeds up, here everything slows down. Okay, here's a video for you to watch, and I'll put that link on the Moodle page. When it comes to hypothyroidism classification, primary hypothyroidism can be caused by any of these listed factors here. You'll note here most common ones could be iron deficiency, could also be postpartum as well, and drug-induced could be as well, and sometimes it could be subacute from a viral infection. We also do have secondary and tertiary hypothyroidism, where the pituitary or hypothalamus is a problem and the TSH cannot be produced adequately, so the thyroid is understimulated. And then we also have peripheral hypothyroidism, where very rare condition where tissues are resistant to the thyroid hormone. Okay. With regards to epidemiology of hypothyroidism, it is quite common, much more common than hyperthyroidism. Around 1 to 2% of the total population have it, with females being affected 10 times more than males. We also have subclinical hypothyroidism, so that's even more common, where many people have raised TSH but normal FT4s and may or may not have symptoms. So with regards to etiology, iron deficiency is the most common cause, especially in mountainous or inland regions with low natural iodine availability. In iodine-replete countries such as the UK, overwhelming majority, around 95% of adult cases, are due to autoimmune thyroiditis, particularly Hashimoto's thyroiditis. Other causes include drug-induced, such as drugs such as amiodarone, lithium. Previous treatment of hyperthyroidism can induce hypothyroidism. Some congenital disorders can cause it, as well as either hypothalamic or pituitary disease. In rare cases, patients become hypothyroid due to excess iodine exposure, for example, from topical iodine antiseptics in the neonates. So it's very important to see that there are varied causes of thyroid disorders, and in this case, hypothyroidism. So how is it diagnosed? A detailed history helps identify risk factors such as autoimmune disease, thyroid surgery, medication use, and radiotherapy. A physical examination may reveal dry skin, slow speech, hair thinning, and a slowed heart rate. Thyroid function tests, the TFTs, provide the definitive answer. So a high TSH with a low FT4 confirms primary hypothyroidism. In suspected autoimmune hypothyroidism, checking thyroid antibodies, particularly TPO antibodies, helps confirm the diagnosis. It's also important to remember that certain illnesses or medications can temporarily alter TFTs, so interpretation must always consider the clinical context. So when you look at this slide here with regards to the normal within normal range, it's all listed here, but again, that can vary per lab, so it's important to have a look at the lab compare that to the results of the lab they originated from. And most reports, as you are covered in the lab, in the biochemical interpretation module, that the units matter with each blood work or any blood test done. So for hypothyroidism, typically we'll have a high TSH and a low FT4, and this would require treatment. Subclinical hypothyroidism or mild thyroid failure, you could have slightly raised TSH, but the FT4 level could be within the normal reference range. Also, you could have a low TSH level together with a low FT4 level, and this indicates a disorder of the pituitary. Okay. So there are diverse symptoms for hypothyroidism, which can affect nearly every body system. So the skin and the hair, neuromuscular, metabolic, gastrointestinal, cardiovascular. The key challenge with hypothyroidism is that symptoms can appear subtle or develop gradually, which is why it's important to screen with TFTs when symptoms are vague. Again, the symptoms are just listed here: fatigue, weight gain, feeling extra cold, constipation, hair loss, decrease in sweating, heavy or irregular periods, slow heart rate, brittle nails, irritability and depression, puffy face, muscle or joint pain, insomnia. So it's really varied symptoms here. And I thought I would include this visual here for those of us who are visual learners, just to see again. Trying to put the pointer here, it's not working. Okay, but anyway, pause the video and have a look at the different areas of the body that hypothyroidism would affect, just like I listed here. But this sort of shows that really the whole body can be potentially affected with symptoms. Okay. So one of the most serious endocrine emergencies, the myxedema coma, is rare but potentially fatal complication of severe untreated hypothyroidism. Coma can be precipitated by hypothermia, stress, infection, trauma, or certain drugs, notably beta blockers and respiratory depressants such as anesthetics, narcotics, phenothiazines, and hypnotics. So medical emergency must be treated rapidly and aggressively. The term myxedema used to be synonymous with hypothyroidism, but now it's reserved for advanced disease in which there is swelling of the skin and subcutaneous tissues. So think of this as the extreme end of the hypothyroid spectrum. When it comes to classifications, they are listed here. We have primary, secondary, and peripheral. So under primary, they are broken down to congenital, immune, iatrogenic, drug-induced, iron deficiency as well, and could be viral related. And then secondary, tertiary, again, remember it's up from the hypopituitary malfunction there. And peripheral is insensitivity to the thyroid hormones. Okay. With regards to clinical manifestations, so the symptoms are frequently vague, especially in the early stages, can be attributed to aging if the person has advanced age. Patients who have read about it or friends have it assume, and they relate the symptoms to fatigue and weight gain, and often confuse it with simple obesity or depression. So most patients don't really know what is going on with them. Signs include TFTs to give accurate diagnosis in all cases, as well as a myotonic test could be done for tendon reflexes. Bradycardia is another test. Hair loss, dry skin. Some people can present with mild microcytic anemia that does respond to thyroxine replacement, and some people also can present with pernicious anemia. And then there's some people who have organ-specific autoimmune diseases such as Addison disease may be associated with this as well. Okay. So in regards to treatment, the first-line treatment for hypothyroidism or primary hypothyroidism is levothyroxine or synthetic T4 as we know it. So the mode of action is the synthetic form of the T4, so provides a replacement hormone to correct the deficiency in production. So really, it's almost similar to how insulin is used to replace the insulin that's missing in type 1 diabetes. It's an oral medication. I think most of us may have come across this. And starting dose for most people who are below 65 years of age with no pre-existing cardiovascular conditions is 1.6 micrograms per kilogram daily, and it's rounded up to the nearest 25 micrograms. So initially 100 micrograms daily, preferably taken before breakfast or the first meal of the day. Then the dose is adjusted every 3 to 4 weeks at 25 to 50 microgram intervals until normal metabolism is steadily maintained. The final usual dose may be up to 100 to 200 micrograms. And in people aged over 65, we start at a lower dose and at 25 to 50, which can be titrated up slowly over 4 weeks in steps of 25 micrograms until therapeutic effect is achieved. The aim is to maintain thyroid stimulating hormone levels within the range when treating primary hypothyroidism. So that's why the routine blood work will be important. I thought I would recap here just to remind you of the endogenous thyroxine, what it's responsible for, the daily production. So it's around at 80 to 100 micrograms of the T4 and around 10 micrograms of the T3. And then what happens to it, it goes around and then has that negative feedback loop that's associated with the hypothalamus and the pituitary gland. Remember, when you have hypothyroidism, there's a malfunction of this process, and that's why you need to supplement the thyroid hormone. Just to remind everyone. And also, I thought this will also just justify or probably remind us where those microgram dosing units came from. This is where they would have come from. Okay, so when it comes to cautions and contraindications, so if you have hypothyroidism, of course, it's a contraindication. If you have hypersensitivity, but also if somebody has potential uncontrolled adrenal insufficiency, that will be contraindicated. Side effects include flushing, restlessness, palpitations or excessive sweating, and rarely insomnia, onset of angina, or even a thyroxic crisis. Main interactions with the thyroid hormone, it can be reduced by ferrous sulfate, calcium supplements, and cholestyramine. So food intake can reduce absorption of levothyroxine by up to 80%. I think that's why most of us know we always recommend that it's taken half an hour before the first meal of the day. So caution, it is a prohormone, and it's hepatically metabolized to active form the T3. So any drugs that affect enzymes such as phenytoin, carbamazepine, rifampicin, so these are the CYP enzyme inducers, may also impact therapeutic levels of a T4. So that's important there. And as well, we'll see why some people end up being put on the T3. And monitoring of TSH should be at least every 6 to 8 weeks and until symptoms are improved. Okay. With regards to counseling, so we would tell the person that the food intake does reduce the absorption by up to 80%. So historically, patients have been counseled to take levothyroxine upon waking up, so 30 minutes before breakfast. So in the BNF, it does say take those daily, preferably 30 to 60 minutes before breakfast. Caffeine-containing liquid coffee or other medication. So with nothing, an empty stomach and just a glass of water. However, studies have shown that taking levothyroxine in the evening or just prior to sleep provides similar biochemical thyroid function test correction. So again, it's what's best for that patient. One must avoid though use together with iron or calcium supplements or at the same time, and these must be spaced by at least 2 hours and 2 to 4 hours. And this is a cautionary label that appears in all levothyroxine labeling. So shared decision making is important in this aspect because the best advice for patients to take the medication on an empty stomach at the time that best fits their lifestyle, as long as they do so daily. So you can appreciate here if somebody works overnight, so that the morning breakfast may not be the best time for them and all that. So it's important to consider what else is going on in their lives before we recommend the time of dosing. In 2021, there was an MHRA drug safety update, so new prescribing advice for patients who experience symptoms when switching between different levothyroxine products. So it's in patient reports persistent symptoms when switching between different levothyroxine tablet formulations. So consider consistently prescribing a specific product known to be well tolerated by the patient. I know this happened when people were maybe on the same dose and they were stabilized on it, and then maybe a generic switch occurred and some people end up losing that control. If symptoms of poor control of thyroid function persist despite adhering to specific product, consider prescribing levothyroxine in an oral solution formulation. That's what the MHRA recommended back in 2021. Okay, so moving on to T3 replacement therapy, so liothyronine. Liothyronine is not first-line therapy. It's reserved for rare cases where patients are generally intolerant of the L4, or where specialist endocrinologists feel it is appropriate. So T3 works quickly, effects appear within hours, but the rapid fluctuations increase the risk of palpitations, arrhythmias, and bone loss. So typically starting dose is around 10 to 20 micrograms. Again, remember when we said naturally it does occur in the body endogenously as around 10 micrograms. So this can be taken up to 2 to 3 times daily. Because of its potency, cost, as well as limited evidence supporting routine use, T3 should always be prescribed under specialist guidance. So most of us will probably have not seen this very well. But in my practice, I've probably seen a handful of people who have been on it, and that's the only one that could be on just for other various reasons. And the T4, they just didn't respond well to T4. So interactions, it does interact with amiodarone and anticoagulants and phenytoin as well, but monitoring importantly here, a baseline ECG is recommended before starting therapy. Okay, and patients should undergo cardiovascular monitoring during treatment. Okay, regular TFTs are important, and also treatment. This will help reduce either over-treatment or under-treatment, and TFTs every 6 to 8 weeks until stabilized, then every 3 months. So the risk of over-treatment include AFib, osteoporosis, and bone fractures. So it's really important that this is routinely done. And certainly in my previous practice, we had people on a regular, I think we did every 6 weeks until they're stabilized, and then every 3 months. And then we could adjust their doses accordingly. So with regards to TFT interpretation, so following treatment with hypothyroidism, recovery of previously suppressed thyroid stimulating hormone can be delayed. So initiation of levothyroxine therapy can occur. Also, when there's non-adherence with the T4 therapy, additional doses in the days before monitoring can produce raised TSH and raised free FT4, so timing of the blood test. So this really helps us interpret those results. Good for us to have the full picture as we interpret that blood work that comes back. Okay. There's also a diurnal variation in the normal nocturnal peak of TSH may be delayed in night shift workers, those with irregular sleeping patterns after vigorous exercise, or in mood disorders such as depression. So that's really important for us to consider. And then there's also non-thyroidal illness, so sick euthyroid syndrome, which is a wide range of acute or chronic non-thyroidal conditions, starvation and trauma that can lead to abnormal TFTs, which are not due to true dysfunction of the HPT axis. Okay, so TSH can be normal or low, then becomes high during recovery from acute illness. So again, it's really important to interpret the results based on everything else going on with the patient. Something else to consider, if there's any adrenal insufficiency in obesity as well, that axis may be impaired. Age is also a factor to consider, and also medicines the person takes. So biotin-containing products and kelp-containing products may contain excess iodine and may make those results harder to interpret. So it's important. So this may produce apparently abnormal results despite normal physiology. So it's important that the interpretation must always be in the wider context, clinical context, and not in isolation. This is again, you can review this under UK guidelines for use of thyroid function tests. Sometimes therapy failure can occur when somebody is taking levothyroxine, where the TSH remains elevated. And common causes could include, well, first and foremost, poor adherence. If they're not taking the medication, then they will not get better. But there's also decreased bioavailability, insufficient dose, drug-drug interactions, malabsorption, especially in people with like PPI therapy, so Chlorhydria is a cause of this, could be a cause, or even celiac disease is a cause, IBD is a cause, increased levothyroxine requirements could be one of it if somebody's on oral estrogen or if they're pregnant. Weight gain could be a cause because then there's more surface area for the drug to go into. New medication prescribed that increases levothyroxine metabolism, so the potent CYP inducers are ones to consider here. Then we have nephrotic syndrome, could be a cause also, and other factors include Addison's disease and also any interference in the culture itself, in the sample. So alternative therapy, so consider a trial of combined T3 and T4 in some circumstances. For example, if there's a proven diagnosis of overt primary hypothyroidism, if they persist out with the L4 alone, if L4 has been administered appropriately, but the TSH does not respond, or if there are comorbidities rather to explain persistent symptoms have been excluded. So this is important. An endocrinologist is most of the time involved here, and they must be willing to initiate and supervise this trial. Normally lasts between 3 to 6 months of both. And if it does not, and if there's no improvement up to 6 months, then the person can just be kept back on the L4 monotherapy. So monitoring, again, is really important, measuring those TSH levels every 3 months once they're stabilized, and then annually thereafter. Okay, and then measuring the T4 if symptoms persist after taking the L4. So that's not a routine test, but you could see it just depends, varies per practice. In my previous practice, we routinely did both. Just remember that thyroid monitoring is not one size fits all. So this is a really, really good diagram here that just gives you a snapshot of everything, the thyroid disease management, hypothyroidism, hyperthyroidism, and the actions of all and why some people would present the way they do. So have a look, have the pause of this video and have a look, and I'll also load this on the Moodle page if anyone would like to print it. So just to summarize, thyroid dysfunction is common in clinical practice. Iodine deficiency is the most common type cause of it. So hypothyroidism, it's a chronic condition, so it requires lifelong therapy. Some medications may cause it. Some medications interact with it with the L4, so it's important that that is considered when it's prescribed. Remember, thyroxine replacement therapy should be introduced with caution in the elderly. And some people with adherence issues, I have seen some people taking it on a weekly basis, so then the weekly dose has to be calculated. Again, just to summarize here, just about hyperthyroidism in this case, just have a look here. Okay, and then here the references that I use, and I will include those in the Moodle page. Thank you again for listening, and for any questions, please post on the Moodle forum. Thank you.